Okay, so we're live now. So I have the great pleasure of introducing Dr. Tyler VanderWeele. Dr. VanderWeele is John Loeb and Francis Lehman Loeb Professor of Epidemiology in the departments of Epidemiology and Biostatistics at Harvard's T.H. Chan School of Public Health. And he's also director of the Human Flourishing program there, which he started, and co-director of the Initiative on Health, Religion, and Spirituality there at Harvard. He holds degrees from University of Oxford, University of Pennsylvania, and Harvard in mathematics, philosophy, theology, finance, and biostatistics. Tyler is a pretty talented fella with extensive training in statistics, methodology, and so this is just a perfect topic for him to speak on. In fact, some of his work, some of the books that he's published on longitudinal data analyses are the primary books in the field of statistics on this topic. So we are just so pleased to have him here. He's also the recipient of the 2017 President's Award from the Committee of Presidents of Statistical Societies. He's also published over 300 peer-reviewed papers, is the author of several books on, a lot of it has to do with on causal inference in prospective studies. And he's also writes a monthly blog on topics related to human flourishing in psychology today. So there isn't too much more I could say about Tyler, other than that he's a good friend and he's been frequently a co-author with me. So I'm just so excited to welcome Tyler, and take it away.
Wonderful. Well, thank you for the kind introduction, Harold, and it really is a pleasure being with you all today. My topic for today's seminar is religion and mental health. Is the relationship causal? So I plan to make some remarks on study design and methodology. I'll try not to bore you too much with technical details of statistics, but I do think these methodological issues are especially important in work on religion and health, because there's often skepticism from the medical community, from the public health community. And so I think carrying out the most rigorous analyses is important. So I will make throughout the presentation some remarks on methodological and study design issues. I'll then be going through a series of analyses looking at associations between religious participation and depression, suicide, and anxiety from using nurses' health study data and some other data sources as well. And then we'll conclude with brief discussion with regard to implications for public health and clinical practice. And I hope to have some time at the very end for further discussion and questions on pondering these implications. I'd also like to acknowledge funding from the John Templeton Foundation. So nearly 100 years ago, Freud wrote about religion, that religion works by distorting the picture of the real world in an illusional manner, by forcibly fixing adherents in a state of psychical infantilism, and by drawing them into mass delusion. But 4 decades later, a review back in the American Journal of Psychiatry was written, the contention that religion as an institution has been instrumental in fostering general well-being is not supported by empirical data. There are no scientific studies that show that religion is capable of serving mental health. If we fast forward then another 50 years, the evidence in the picture, in fact, looks quite different. And there have been numerous, hundreds of papers showing that religious participation is associated, for example, with lower depression. In Harold's handbook, the second edition published in 2012, and I'm working with him now on trying to complete the third, but the statistics from the second edition are themselves quite illuminating. Even by that point, 10 years ago, of 272 cross-sectional studies published since 2000, 63% suggested a protective association between religious participation in depression, only 6% suggested any sort of detrimental association. Of 45 cohort studies over time, so more rigorous design since 2000, 47% suggested a protective association, only 11% detrimental. So it looked, good evidence that association between religious participation and lower depression. But also striking from this is that the vast majority of these observational studies are cross-sectional. And in fact, this is problematic. It's problematic because effects may also operate in the reverse direction. And in fact, in 2012, same year as the handbook, Masalko and colleagues showed using longitudinal data evidence for an effect in the reverse direction, that women who were depressed by age 18 were more likely to cease attending services. So that there might be effects in both directions, but this basically renders cross-sectional data useless for analyzing these questions of causality. It's useless because if there's an effect in the reverse direction, if those who are depressed stop attending services, then it may be that we see an association between religious service attendance and lower depression just because those who are depressed stop attending. And so we really need data over time to be able to sort these questions out. There have, however, been quite a number of large, well-designed longitudinal studies suggesting evidence for an effect, protective effect of service attendance on direction. Is just one of many examples. Paper by Strawbridge, 2001, using longitudinal data about 2,700 participants, showed that those who attended services at least once a week, who were depressed at baseline, had about 2 times larger odds of recovery subsequently. And again, many other studies, and just recently, earlier this year, there was a meta-analysis of studies looking at religious service attendance and depression, finding similar results restricted to these more rigorous longitudinal studies. But these analyses of Masalko et al. Do make clear that really cross-sectional data shouldn't be used for these purposes of trying to assess evidence for causal effects. There really may be effects in both directions. And more generally, in thinking about the quality of evidence, I think it can be helpful to consider kind of a hierarchy of different designs with regard to the level of rigor, to robustness, to confounding, and potential reverse causation. I published a short piece on this earlier this year in JAMA Psychiatry, arguing for this, but kind of at the lowest level of the hierarchy is cross-sectional designs, and there we really can't tell anything typically about the direction of causation. It might establish that there's an association to be investigated, but that's about it. The next best would be longitudinal or cohort follow-up studies that adjust for various demographic covariates and other potential confounding variables. The next best level, and I would, in my view, consider this kind of the minimum bar for really providing evidence for potential causation, would be a longitudinal cohort study that controls for confounders, but also controls for the outcome at baseline. So if you're looking at the effects of service attendance on depression, you want to control for depressive symptoms or clinical depression at baseline to try to rule out that possibility of reverse causation. Better yet still is adjusting for prior levels of the exposure, so prior levels of religious service attendance. That really allows you to get at what do changes in religious service attendance do to the outcome that you care about. It also helps rule out, as I'll discuss briefly further momentarily, potential unmeasured confounding and reverse causation. Better yet still is if we can look at a whole trajectory of changes in service attendance over time and changes in depression over time, then we can really work out what is preceding what. And of course, for establishing causation, the gold standard is considered a randomized trial, but typically with matters of religion and spirituality, we can't really randomize this in any conventional way. So often we are left with observational data, but we want to get sort of as high up the hierarchy of evidence as possible, ideally. And again, I think too many of the studies on religion and health have been cross-sectional in nature, though increasing numbers are longitudinal. So why do we want this longitudinal data? Well, again, if we're interested in looking at the effect of attendance on our outcome, depressive symptoms, it might be that prior levels of depression lead to lower levels of attendance and higher levels of depression symptoms. So even if there's no effect whatsoever of attendance on depression, we'd observe an association simply because those who became depressed stopped attending services. So we want to rule that out. And so what we do ideally is control for prior levels of depression. That can rule out, if we still observe an association between current service attendance and subsequent depression, controlling for prior depression, it helps us rule out that possibility. And it will do so provided that it's not kind of the whole history of depression that's affecting service attendance. So if it's only the most recent depression, then that approach will suffice. If otherwise, we may want to control again for prior levels of service attendance as well to yet better rule out the possibility of reverse causation. Controlling for prior levels of service attendance also helps rule out potential unmeasured confounding. And to understand this, we might worry that certain personality factors, maybe conscientiousness or agreeableness, they've been shown to be associated both with increased service attendance, but also with lower levels of depression. So we might be worried about confounding. And often many of these analyses don't control for these personality factors. But if we control for past attendance, then for such unmeasured confounders to explain away our associations, they'd have to affect current attendance substantially through pathways independent of past attendance. And so it doesn't completely eliminate this problem, but it reduces it substantially. So when the data allow and sample sizes are large enough and we have lots of measurements over time, it can be helpful to control for past levels of attendance as well. Again, even yet better. So ideally, we want to control for past outcome, past depressive symptoms. Even better is controlling for past outcome and past exposure, past attendance. Yet better still, again, is looking at whole trajectories. And we need different types of models to deal with these issues of feedback if we have a long trajectory of service attendance and trajectory of depression. But techniques called marginal structural models developed by Jamie Robbins at the School of Public Health at Harvard have become quite popular within epidemiology for handling these questions of causal inference can be a yet further step forward with regard to the strength of evidence. These methods, and I won't go into all the technical details, but these evidence allow for feedback. These models allow for feedback between attendance and depression over time. They control for confounding by a weighting approach that's kind of similar to a propensity score approaches and weighting. For those who are familiar with them, it's sort of a longitudinal generalization of propensity score methods. So again, I'm not going to go into all the technical details here, but I think using these methods, we can have even stronger evidence. And I've given a tutorial on these methods in the context of religion and health in the Journal of Social Psychiatry and Psychiatric Epidemiology. I'm happy to make these slides publicly available for anyone who wants to follow up on this material. I've got a list of references at the end as well. So I'm going to make use of these marginal structural models, which can control for past attendance and past depression, and look at whole trajectories to try to establish the strongest possible evidence for an effect of service attendance on depressive symptoms. And this is using data from the Nurses' Health Study at Harvard, a very large longitudinal cohort study of thousands and thousands of nurses. Data collection began in the 70s, but starting in 1992, they began measuring religious service attendance as a kind of component of social integration every 4 years. And so this is the data we'll be making use of. This particular analysis includes about 48,000 US nurses, mean age 58 at baseline. Service attendance was self-reported every 4 years from 92 onwards. Depression was self-reported as a physician-diagnosed clinical depression or antidepressant use in 92 and every 4 years subsequently, and we'll treat that as kind of a binary measure of depression, but also we'll reanalyze the data using a continuous measure of depressive symptoms using the CESD scale. And as you'll see in the next slide, controlling for kind of a rich set of covariates along with prior levels of attendance and depression. So our primary exposure periods are going to be service attendance in 96 and in 2000. But we're going to control for prior levels of service attendance and depression in 1992, along with a rich set of covariates in 1992. But the kind of the scientific substantive question of interest here is the joint effects of service attendance in 96 and 2000 on subsequent depression or depressive symptoms in 2004. So again, these analyses are controlling, trying to establish more rigorous evidence for baseline of service attendance, for baseline depression, along with a variety of social and demographic variables, age, race, ethnicity, geographic region, various socioeconomic variables, employment status, education level, census tract income, various social variables, marital status, living arrangement, number of close friends, and so forth, and a wide range of health variables and health behaviors as well. So when we fit these marginal structural models, these are the results we get. If we focus first on the effect of service attendance in 2000, we can see these are odds ratios, but we can see that the greater the level of service attendance, the lower the risk of subsequent depression in 2004. So for those attending more than weekly in 2000, odds ratio of 0.71, essentially a 29% reduction in the odds of depression in 2000. For those attending weekly, about a 25% reduction. Those less than weekly, about a 13% reduction. The confidence intervals are given here, all excluding one. And likewise, sort of similar effects if we look at depression treated continuously. We see a kind of once again a dose response where the greater the attendance, the larger the reduction in depressive symptoms. If we turn to service attendance in 96, this is kind of the independent effect of service attendance in 96 on final depression, not through service attendance in 2000. We really don't see much going on. Confidence intervals here all include 1. So it really seems that most recent attendance is relevant for protecting against depression, but again, consistent evidence across binary or continuous outcomes. Interestingly, though, if we turn the question around and we also ask in a separate analysis, is there evidence that those who become depressed stop attending? We do find evidence in the reverse direction also. So it seems that both are the case. Service attendance protects against depression, but it's also the case that those who become depressed stop attending services. And I'll come back to this point momentarily. But again, if we turn the analysis around, those who are depressed in 2000 have about a 26% reduction in the odds of attending services in 2004. And here it looks like there's in fact also a persistent effect where in 96, those who are depressed, there's an independent effect of reducing the odds of service attendance in 2004 by about 10%, not huge, and confidence interval somewhat wider, but some evidence that even depression further back affects current attendance. So again, it does seem there to be evidence that there are effects in both directions. Now, this is observational data. We've tried to control for a rich set of confounders. We've controlled for baseline outcome, baseline depression, and prior service attendance, but it's always possible that there's some unmeasured confounder explaining away these relationships. Again, something like personality, agreeableness, or conscientiousness might confound these relationships. And so what one can do to try to address these issues is use sensitivity analysis to ask how strong would an unmeasured confounder have to be to explain away these results. And I've done a fair bit of methodological work on these questions. A very simple, easy to use approach can be found in this paper in the Annals of Internal Medicine. It's called the E-value. This approach has become quite popular in the sort of 3.5 years since it was published. I think it's been cited now over 1,000 times because it's pretty easy to use, and we've got an online E-value calculator as well to do this. But if you apply these sorts of methods, one can draw conclusions like to explain away our estimate of the odds ratio 7-1 for the reduction in the odds of depression for those attending services 4 years earlier. To explain away that estimate, an unmeasured confounder like personality, conscientiousness, or agreeableness that was associated with both increased attendance and with lower depression, each by 2.1-fold, above and beyond everything we've already controlled for. That would suffice to explain it away, but weaker confounding could not. So the unmeasured confounder, if it increased the likelihood of service attendance by 2-fold and decreased the likelihood of depression by 2-fold, then that could explain away the estimate, but weaker confounding could not. So these would be pretty strong effects. If you look at the actual associations with something like conscientiousness or agreeableness, they're much smaller. It's more like 1.2, 1.3, not 2.1. So this is observational data. We can't be certain, but the evidence suggests that it would be very difficult to explain away these associations by unmeasured confounding, given all that we've controlled for. Even to get the confidence interval to shift it to 1 would require an unmeasured confounder associated with increased attendance and decreased depression by 1.7-fold each, above and beyond the measured covariates to do so. So again, I think reasonably good evidence that at least some of this association really is causal. And again, if you want to implement these sorts of techniques with your own analyses, you're welcome to do so. Little tutorial paper there, and we've got these online eValue resources as well, which you can make use of. So in some sense, these analyses really just confirmed, I think, what was already fairly well established in the literature, that there does seem to be a protective effect of service attendance on depression, but we did so with better study design, repeated measures on both service attendance and depression, larger study, 50,000 women, and these methods to address feedback. But I do think the effects in the reverse direction are just as important. There's evidence that those who become depressed stop attending services. And I think this has important implications for religious communities, for example, that for those who become depressed, support needs to be offered. These individuals need to be identified and provided care before they cease attending the services, before they withdraw from their religious communities and other forms of community life, which might then further exacerbate depression. So I do think the effects in the reverse direction are also really important. But these methods that allow for feedback in both directions, I think, can provide these sorts of important insights. So I'm going to turn to suicide somewhat more briefly, using kind of similar data and somewhat similar methods, but major world religious traditions typically strongly prohibit suicide. Prohibitions especially strong within Islam, Judaism, and Christianity, but certainly also present with Buddhist, Taoist, Confucian, Hindu traditions. This topic of religion and suicide is also interesting because one of the very earliest studies on religion and health, work of Durkheim, was on this topic of suicide, and Durkheim noted that there were differences in suicide rates between Catholic and Protestant regions. Suicide rates within Catholic regions tended to be somewhat lower, and he attributed this to greater social integration and control with Catholics. So this was one of the earliest studies on religion and health. The Durkheim used what are sometimes called ecologic or group average data. These, in some sense, are even weaker than cross-sectional data because you're not even using the data on individuals, but just averages across groups, which can confuse causal relationships yet further. But we'll be revisiting Durkheim's analyses with more rigorous longitudinal data here. So this work was published in JAMA Psychiatry about five years ago, again, using the same data, the Nurses' Health Study data, once again, using service attendance as in 1996 as our exposure, controlling for past attendance and past depression in 1992, along with a large range of confounders, and we fit proportional hazards models to this data. Completed suicide is not an easy topic to study because it's thankfully a relatively rare outcome. And this sample, I think this analysis included something like 90,000 nurses. There were, again, thankfully, only 36 suicide events over the follow-up through 2012. So kind of good from the perspective of the health of these women, but it does make it more difficult to draw definitive conclusions with such few events. And to try to accommodate this, we used another statistical technique, exact logistic regression, which is better for handling kind of very rare events, but you typically have to control for fewer covariates. So as a sort of an additional analysis, we beyond the proportional hazards model, we also use these exact logistic regression techniques, controlling just for depression and prior social support, which we thought might be the two most important confounders here. The results from these two approaches were remarkably similar. Hazards ratio from the proportional hazards model of 0.16, confidence interval 0.06 to 0.46, the exact logistic regression odds ratio of 0.17, very similar confidence interval. So this is like an 83% reduction in suicide for those attending at least weekly, like a 5 or 6-fold reduction in suicide risk given by service attendants. If we apply similar e-value sensitivity analysis techniques, we can to this data, to see if unmeasured confounding could explain this away. We're at the conclusions like to explain away the hazards ratio of 0.16, a confounder that was associated with both greater attendance and reduced suicide by risk ratios of 12-fold each could suffice, but weaker confounding could not. To explain away the upper confidence limit of 0.46, a confounder that was associated with both greater attendance and reduced suicide by 3.7-fold each could suffice. So we really need very, very strong confounding to completely explain away these associations. Once again, it seems like at least some of this association really is causal. I mean, interestingly, these are fairly similar estimates to what were obtained in prior, I think, reasonably well-designed case control studies. Many of the estimates range from about a 3-fold to a 6-fold reduction in suicide risk for weekly attendance. At the time this paper was published, there was only one prior longitudinal study with completed suicide as the outcome, many others on suicide ideation or suicide attempts. But that one prior longitudinal study hadn't controlled for baseline depression, which I think is problematic because that is a potential confounder. It leads to lower levels of attendance and, of course, increased suicide. There has been, I think, increasing evidence since then, a number of other longitudinal studies, well-designed, that have been published since, and we've summarized some of the evidence in one of the chapters in Harold Koenig and David Rosemarin's handbook on spirituality, religion, and mental health, just published last year. One of those studies was just published also last year in JAMA Psychiatry, looking at association between religious service attendance and deaths of despair, suicide, deaths by drug overdose, and deaths by alcohol poisoning. And likewise, fairly large effects, kind of a 3-fold reduction in deaths of despair for women, about 33% reduction for men. Those stronger effects on suicide than on drug overdose or alcohol poisoning, especially that was especially so for men. So the evidence on suicide, I think, has continued to accumulate since the publication of this paper. We did also look at differences in effects for Catholics versus Protestants in terms of the effect of service attendance itself. We've done so in other analyses for depression and for mortality, and we've really found very few Protestant Catholic differences. Suicide was the one exception where we did find differences. And here, for Protestants attending weekly, there was still a pretty large effect, hazard ratio of 0.34, kind of a 3-fold reduction. But for Catholics attending weekly, our estimate was a hazard ratio of 0.05, like a 95% reduction, a 20-fold reduction in suicide rate. So important and large effects for both Catholics and Protestants, but evidence for a larger effect amongst Catholics. Interestingly, no Protestant Catholic difference for those not attending services. So it really does seem to be driven by, the Catholic Protestant difference seems to be driven by service attendance. And I think this would be kind of consistent with Durkheim's hypothesized mechanisms of social integration and social control. But again, this is sort of the only health outcome we've seen thus far where we've observed substantial Catholic Protestant differences. we did try to do some work on understanding the mechanisms here. And it's another topic I have studied from a methodological perspective. I have a whole book on mediation analysis, which if you're interested, you're welcome to acquire, or if you're having trouble sleeping at night, it's a very good remedy for that as well. But we weren't, because of the sort of only having 36 suicide events, we weren't able to employ some of those more sophisticated methods. So what we did is we tried to repeat the analysis, which we did, but controlling for potential mediators in 1998 or 2000, subsequent to our religious service attendance exposure in 96. And when we looked at what that did to those who are attending less than once a week, as we controlled for social integration and alcohol consumption and depressive symptoms, which we thought might be important mediators, explained away some of the association with those who were just attending less than once a week. It was not a very strong association to begin with. There's much stronger association for those attending weekly, and for this group, when we controlled for these potential mediators, it really didn't change the estimate very much at all. So we were a little surprised by this. We thought these might be important mechanisms, and I do think they play some role, just maybe not as substantial as we had thought. So our speculation here is that it might really be the moral belief that suicide is wrong that is driving these large associations. But more work on this is needed. More work on what these mechanisms might be. And then the final outcome I wanted to turn to even more briefly is anxiety. And again, in Harold's handbook in 2012. Reports that 147 of 299 studies suggested that religious involvement was associated with lower anxiety. 11% of them maybe greater anxiety, and quite a few, nearly half, suggested no relation. Most of these are cross-sectional. And interestingly, kind of unlike with depression and suicide, if you look at the more rigorous studies for anxiety and look at religious service attendance as the exposure, I would say the longitudinal studies suggest either little or no effect of religious service attendance on anxiety, and sort of the most comprehensive analysis we've done thus far, with 90,000 participants from 3 different cohorts at differing ages. When we combined all of the evidence together, we found a tiny effect, 0.05 standard deviations, like a 20th of a standard deviation. But this is pretty small, and so maybe on average there's a protective effect, but it's not big. It's much smaller, it seems, for anxiety than for depression, where I think it's quite notable, or suicide, where it's one of the strongest, if not the strongest, protective factor. I think some people, when they see these results, are a little surprised. I've had response as well. If religious practice is doing anything, certainly it should be bringing peace and relieving anxiety. And I do think that's the case for some. And I think that can be a really powerful experience. But these are averages across the population. So it might be protecting against anxiety and bringing peace to some, but it might be a source of anxiety, of potential conflict, additional set of responsibilities, or anxiety over not living up to the standards of religious teachings. I think it can create anxiety for others, and the net effect, again, doesn't seem all that substantial. Again, unlike depression and suicide. Importantly, this is just for religious service attendance. I think there's maybe other evidence that suggests that practices like prayer or meditation may be more important for anxiety than is religious service attendance, where religious service attendance really seems to be the principal driver of associations with depression, with suicide, with longevity as well. But again, much more modest with anxiety. I'm not going to go through all of this, but I think there is now good evidence from, again, rigorous, well-designed longitudinal studies for similar associations between religious service attendance and a wide range of other health and well-being outcomes, including lower all-cause mortality, a risk, sort of 25, 30% reduction in say 10-year all-cause mortality risk, higher levels of life satisfaction and happiness, higher levels of meaning and purpose, less substance abuse, and fairly large effect sizes with substance abuse as well, less crime, greater social relationships and social support, greater marriage stability, about 30 to 50% reduction in divorce for those attending weekly, greater generosity, volunteering, civic engagement, pro-social behavior. So a wide range of outcomes. Again, not all outcomes. I would say sort of, if you look at diabetes or incidence of cancer or anxiety, the effects are either non-existent or very small. But for a wide range of really important outcomes, one does see pretty sizable effects. So I really do think religious participation, religious community is a critical social determinant of health. So what are the implications of this work? And I want to spend 10, 15 minutes very briefly sharing my own ponderings on this topic. And I'll discuss first implications for research, second for population health, public health and well-being, and then lastly, and perhaps most controversially, clinical practice. With regard to research, I really think we need a move towards more rigorous studies with longitudinal designs, controlling for baseline outcome. And the quality of this work has been improving over the years. But better for some outcomes like depression than for others, like happiness and life satisfaction, where although there have been more than 100 studies published on this topic, something like 99 out of 100 use cross-sectional data. It's easier to obtain, but again, we can't tell what direction causation operates. So again, when there's any possibility that there are effects in both directions, then cross-sectional data is effectively useless for addressing these questions of causal inference. I think we should try to move towards designs that use longitudinal data, stop employing cross-sectional data. If at least 2 or 3 studies have already established an association, then there's no reason to employ cross-sectional data anymore. Try to find longitudinal data resources. And I think ideally these cross-sectional studies would be excluded from systematic reviews or kept in a separate section, as well as for meta-analyses. I think we need the next step in building evidence would be meta-analyses of rigorous longitudinal studies with control for baseline outcome. Now that was done about 10 years ago for all-cause mortality, done just earlier this year for depression and psychological distress, but we need to move towards these meta-analyses of longitudinal studies with control for baseline outcome to really establish the most rigorous evidence. So I think we're moving in the right direction, but more effort here is needed as well. So its implications for research. As regards public health, and I really do think we need to take seriously religious community, religious service attendance as an important social determinant of health. Often in public health, we assess public health impact as a function of 2 things. First, the prevalence of the exposure that we're studying, and secondly, the size of its effects. Anything that's common in the population and has large effects is going to shape population health. And I think a strong case can be made that religious service attendance is one of these critical social determinants of health. It's common. Approximately 84% of the world's population report a religious affiliation. Worldwide, it's common in the United States. 89% believe in God, 78% consider religion a very important part of life, 79% identify with a particular religious group, 36% report having attended a religious service in the last week. That was 2016 data. That's come down a bit to 30% or so right now. But again, still very common. And as we've seen, the effect sizes are pretty large. So again, I think on these grounds, we need to take seriously religious participation as an important social determinant of health. I think it should be included in public health curricula, and Harold and I have written a little piece on this as well. Doug Oman has a whole book documenting the increase in uptake of these ideas within schools of public health, but there's a lot of work to be done still. I think most schools of public health in this country and worldwide tend to ignore these issues. But again, I think the evidence now is strong. And again, these phenomena have important implications for population health. As just one example, the CDC not long ago expressed concern about increasing suicide rates in the United States between 1999 and 2004. The rate increased from 10.5 per 100,000 per year to 13 per 100,000 per year. During that same period, the Gallup poll indicated a decline in religious service attendance from 43% to 36%. And if one were to take the estimate from our study with the nurses' health data and extrapolate it to the US population, that is an extrapolation, but if one were to do so, it would suggest that about 40% of the increase in suicide rates was due to declining attendance. And both of these trends have continued since. So I think by ignoring religious service attendance as an important social determinant of health, we're really become blind to the factors that shape population health. I think we need to take these issues seriously within public health. What about clinical practice? Well, things get, I think, even more controversial here, but in my view, there's sort of a sensible way to try to navigate these issues. But there's not been as much discussion of these topics, I think, as there ought to be. I think some of it was because of a piece about 20 years ago, and top medical journals, New England Journal of Medicine by Richard Sloan and colleagues, entitled, somewhat ironically, "Should Physicians Prescribe Religious Activities?" And this piece was arguing that endorsement of service attendance is really premature, it's unethical, you shouldn't be pushing this, that religion can also cause tensions and antagonism, it's difficult for physicians to address these issues because religious views differ, they're not trained to do so, so these issues just shouldn't be discussed in clinical practice. In a very nice piece that Harold wrote in reply, letter to the editor, pointed out that really Sloan and colleagues were setting up and attacking an extreme position, a straw man, essentially, that no one's suggesting that physicians and other clinicians should be always universally prescribing religious activities, and that's very different from a recognition that such activities might be important in a patient's life and in their understanding of illness. The current recommendations were for clinicians to take a short 4-question spiritual history, and for those who are not religious, the conversation could quickly move on. In another letter, in response to this piece by Sloan and colleagues, David Nicklin wrote that experience could hardly be more in conflict with the conclusions of Sloan et al. Although I do not routinely inquire about patients' religious or spiritual lives, it's not unusual for me to do so. Most frequently, I ask such a question when patients are suffering from progressive, incurable, or fatal illness. It also seems relevant to inquire when patients are struggling with mental anguish or addiction. It's my practice to ask patients whether spirituality or religion is important in their lives. I then listen respectfully to their experience. Some patients report little engagement with these matters, and then we go on to other subjects. Many patients talk of the central part God plays in their lives and in their experience of illness. Some describe the comfort and support they obtain from religious and spiritual sources, and I validate this response and encourage them. Some say they have lost touch with religion and spirituality and wish to reconnect with them, and we discuss that. We then go on to issues of diagnosis and treatment. I've had many hundreds of such conversations, and not a single patient has responded negatively. This information helps inform my approach to patients in discussing their illness and medical choices, sometimes in important ways. I come to know my patients in a deeper way, and they feel seen and heard in ways that matter to them. This approach helps me treat them and heal them, particularly when they are facing incurable illness or death. So I really do think there's a role for sensitively raising questions of religion and spirituality within clinical practice. It needs to be done carefully, it needs to be done well, but many patients do desire this and benefit from this. I think it still raises and leaves the question open, what about discussions of participation in the religious community, religious service attendance? Should this be outside the bounds of clinical practice? Should this come up at all in sort of an annual exam or within psychiatric care? And I think it's a tricky question, but I think, again, there's a sensible way forward. I do think, however, it's important to acknowledge that people generally do not make decisions about religion and religious participation based on health. Religious beliefs and commitments are instead rather shaped by experiences and upbringing, values, truth claims, evidence, relationships, and so on. But I think for those who do already positively self-identify with a religious tradition, it's not, to my mind, unethical to encourage attendance as a meaningful form of social participation. If they already hold these beliefs, they already positively identify with a tradition, then because of these health benefits, I think it's reasonable to say, well, would you want to re-engage with the community that already holds and shares your actual beliefs? I think this needs to be done sensitively. Context is important. I think one wants to be careful with regard to cases of former abuse. And make referrals if necessary. And I do think that can be facilitated by, as Harold and others have advocated, by taking a simple spiritual history. And Harold's put forward a handful of questions to do so. Here are four questions proposed in a piece in JAMA. There are other sample questions as well. This paper by Chelsky contains another set of 4 questions. But sometimes people object to these, saying there's just not enough time in a clinical visit. I think one can perhaps try to simplify yet further, maybe reduce the 4 just to 2 and weave them into a social history, something like, our religion or spirituality important to you in thinking about health and illness or at other times? And do you have, or would you like to have someone to talk to about spiritual matters, really to reduce the time required? But these sorts of questions are, again, they're neutral. They can be asked even as a clinician and the patient don't share similar beliefs, and they don't take much time, but they raise the opportunity for the patients to discuss these matters further. So to my mind, at least, I think a reasonable approach with regard to clinical practice, and I have a forthcoming piece in the American Journal of Epidemiology suggesting this, would be, after taking brief spiritual history using either the 4 questions or the 2 questions, after taking a spiritual history, for those who do positively self-identify with a particular religious tradition, I think for them, religious service attendance could be encouraged. For those who do not, then other forms of community participation could be encouraged as well. There's evidence that other forms of community participation have effects on health and well-being. The effect sizes tend to be somewhat smaller than religious service attendance, but they're still meaningful. So I think this sort of 2-pronged approach really does help address everyone and would strengthen communities and benefit the patient's health. And you're not telling patients to become religious on health grounds. You're not instrumentalizing religion. You're saying, well, if you already hold these beliefs, might you want to consider community engagement? And again, for those who have had negative experiences with religious communities in the past, referral to chaplains or counselors or others could be made. I think other considerations here are that and end of life, this is especially important. Palliative care guidelines are to raise questions of religion and spirituality. I think it's important to raise these because sometimes religion and religious doubts and struggles can be a source of struggle and of mental health. So it's another reason to bring these issues up, at least briefly. And then lastly, it's often very important in patient decision-making. One survey suggested that of 7 factors that shape medical decision-making, patients rate religion and spirituality second most important of the 7. Clinicians, or at least physicians, 7th out of 7. So there's a real discrepancy here. So I think for these various reasons, these issues of religion and spirituality should be brought, at least briefly, into clinical care. And I think in some circumstances, it's reasonable to encourage service attendance as well. Again, it needs to be done in a sensible, ethical, patient-centered way, but for those who do positively self-identify, I think it can be encouraged. I think we can also turn the question around and ask, given the effects of service attendance, the evidence that these effects are large, are profound, if we withhold this information, are we in fact doing harm? That concludes my presentation. Thank you all for listening. Happy to take further questions or comments.
Tyler, thank you for a brilliant presentation, as I would expect from you. So thank you so much. Let us now open up for questions. Please unmute yourself and ask your question. And Tyler, stop sharing your screen.
Very good. Yep.
This is Robert McCowan.
See you.
Hi, Tyler. We have met
Yes.
years ago, and I appreciate all your work, and especially today. One of the distressing things that I'm sure all of us have seen is the enormous decline in identification with religious and spiritual practice, and the rise of so-called nuns, not N-U-N-S, but N-O-N-E-S, people who have no religious identification when asked. And this is especially true for the younger generations. Of course, pretty much all the generations are younger than I am, but for I guess so-called millennials and younger. And I wonder if you've thought about the you've alluded to it somewhat, thought about the implications of this and what public health and clinically oriented people how they might respond.
Yeah, and I think that's a good question, a difficult question, but I think one that does have profound implications for society. There has been a very sharp decline in service attendance amongst millennials and younger generations. I think not necessarily a hostility towards spirituality, but often towards more institutional forms of religion. I think this is paralleling the general decline in community participation. I think with regard to religious community in particular, I do think kind of the media's portrayal of religion fairly consistently as negative plays a big part in that. And I think it's important to be honest about the failings of religious communities. And there have certainly been instances where harm has been done. I think the sexual abuse scandals over the past decades are a clear example of this. I think it's an issue that needs to be addressed. We recently hosted a symposium on faith and flourishing, addressing questions of prevention and healing child sexual abuse in religious communities at the Human Flourishing program at Harvard. So I think this is an issue that's serious and needs to be wrestled with, but I think it has led to a pretty substantial decline. So I think religious communities need to do work to address these, but I also think media needs to do a reasonable job of balancing the narrative, pointing out all the profound contributions that religious communities make as well. And I think if that were done more adequately, both in media and at universities and in the academy, I think it would have a substantial influence. So I would point to two approaches, or three approaches, I guess. One, religious communities taking their problems seriously and addressing them. Second, meet more balanced portrayals in media and the academy. And then third, an emphasis on the importance of community life, not just religious community, but other forms of community life. I think this loss of sense of meaning, the increase in difficulties with mental health, I think a lot of it is due to withdrawal of all forms of community life. So I think, especially post-pandemic, we really need to invest in these communities and in rebuilding them.
The things I've read have suggested both the sexual abuse scandals that are not limited to Catholic priests, but we now see emerging in evangelical congregations and across the board. But the other thing is the very strong identification, especially of white evangelicals, with right-wing movements, and how that has turned off a lot of old people as well as young people. And having those groups themselves address those problems is challenging.
Yeah, no, I suspect that is yet another influence. You're right, yes.
Hi, Tyler.
Thank you.
All right, good to see you.
I happen to have the honor of sharing the same last name as Tyler in preface. Tyler, have you ever considered, instead of religious attendance, using as a measure maybe the number of hours in religious activity? For example, just attendance seems to me limiting. Is there any relationship, for example, between working on the food line as a part of a religious organization, be it the Salvation Army or your local church, working, in a variety of, in other words, a spiritual engagement rather than just religious attendance? I'm sure you've got some of that in some of your studies, but I just wondered if you could comment on that.
Yeah, no, it's a good question. I suspect you're right that kind of the deeper the engagement, the more hours, the more substantial the larger the effects. You see that in somewhat in the dose response with regard to less than weekly versus more than weekly attendance. I haven't seen any really good analyses on that. I think some of the difficulty is that the data that has the largest sample sizes and follows up for a long time, usually the measures are very crude, just sort of frequency of attendance. And if we want more detailed studies, then we often have to start from scratch, which is very expensive. But I think another indirect source of evidence towards our point is kind of looking at differences in the effects of attendance across groups. Most studies in the United States, at least, find a larger effect of service attendance for women than for men. Protective effects for both, but larger for women. And maybe there's something profound that has to do with gender, but my speculation is actually it's just the number of hours that people are spending. I think for many men, it's showing up there for an hour and depart. And I think many women, they're much more involved. And so my speculation is that it's that depth of engagement. Likewise, one typically finds larger effects within Black churches than white churches. Again, protective for both, but larger in Black communities. And I think, once again, my speculation would be a lot of that has to do with how involved the congregants are. Are you just showing up for an hour or two, or are you there for the better part of the day and sort of building these communities? And so again, it's indirect evidence, but my speculation is the interpretation of those analyses is that it's really the number of hours, the depth of involvement.
Tyler, you alluded to the notion that even if the nation becomes less religious, that people are just not necessarily less spiritual. They're maybe looking for meaning through other avenues. Has there been any studies on such avenues? Like, for instance, there are atheist churches. They have Sunday services. It's not very many people. And also there are a lot of people who replace religious identification with political identification. So have we looked at, how being a part of, like, I don't know, the socialist movement or whatever political party people belong to, how that is protective?
Yeah, so I mean, on kind of the question of spirituality and private practices, I would say most of the evidence points to not very substantial effects, maybe some, but pretty small, at least with the general population. Dynamics, I think, are quite different at the end of life, but with general populations, I think sort of private spirituality, private practices, though potentially very meaningful and important for spiritual and religious life, don't have the same sort of profound effects on health and well-being. But I do think other forms of community participation do have some effects, possibly more modest, but I think the evidence there is fairly good. I'm not sure if anyone's yet looked at atheist congregations, but if you look at various forms of social participation, you do find effects on health and well-being outcomes. Again, the effect sizes tend to be smaller. I mean, in sort of the nurses' health study data, both for suicide and for mortality, religious service attendance was a stronger predictor of those outcomes than was hours in community groups, time spent with friends, time spent with family, marital status, or the combination of all of those. But that doesn't mean the other forms don't have meaningful effects. They're just somewhat smaller. So I mean, my speculation, and this is speculation, not evidence-based, is that the closer these communities do resemble something like a religious community, which have not just weekly meetings, but also a shared set of values, a shared purpose, a history that extends beyond the lifetime of an individual, the larger the effects are going to be. So that maybe a volunteering organization would have larger effects on health and well-being than would, say, showing up for a weekly card game. Weekly card game, I think, still is going to have some effect, but I think when you unite that community participation with a shared purpose, a shared vision, a shared set of values, I think that's really when these profound effects on health and well-being set in. So again, that's a bit speculative, but looking over all of the evidence, that would be my guess.
Makes sense.
Any last questions?
Yeah, can you hear me?
Yes.
Dr. VanderWeele, quite a fascinating talk. I have a question that I'm not sure if I'm going to be able to articulate very well, but I think I have this question of related to study of health benefits of religious behavior. So there is so much proof that religious behaviors benefit health and mental health. Do you see this as truly aligned with studying the religious truth? Or in other words, in your opinion, do you that religious attendance reflects religious maturity or the accuracy of understanding the religious message, or they're completely different things?
Yeah, no, I think it's a very good and important question. The religious service attendance is a crude measure. There's no doubt about it, and certainly, from the perspective of any religious or theological tradition, there's a lot more to be said than is someone attending services weekly. I do think it's a reasonably good marker with regard to at least some of those attending weekly are taking their the teachings quite seriously, and those who are not attending regularly, probably some are as well, but I think a smaller proportion. So I think it's interesting that it's such a powerful and profound predictor and marker, even though it is such a crude measure. So I think there's important work to be done on what more can we say, and how can we better study religion from the perspectives of what religious communities themselves consider most important. And we've been working on a measure of spiritual well-being that I think needs to be tradition specific. So we've been working on the measure of tradition specific Christian spiritual well-being, but I think that would need to be done separately for, say, Muslim or Jewish or Hindu traditions, because the understanding of what constitutes well-being is really going to differ in fairly substantial ways across traditions. And so we hope with some of this work to be able to make use of empirical methods to help empower religious communities to attain their own ends, the things that they consider most important. But that work is still at a very early stage. I mean, accompanying that, and I think many religious traditions have teachings about faith itself leading sometimes to suffering, and so we've likewise begun additional work on suffering, which I think is distinct from notion like depression. We've got data that these are related but distinct phenomena, and I think again religious spiritual traditions that suffering itself can lead to further growth. So there are subtleties which these very crude analyses are certainly not picking up on. As I've tried to emphasize throughout, these are really just based on averages, and individual experiences are going to be quite different. And I think especially when one's considering the ends of religious communities themselves. There are all sorts of important nuances that we're not picking up here. But nevertheless, it is quite fascinating that as a simple marker of self-reported service attendance has such strong associations over time with health and well-being. I mean, I think it really makes clear that something is taking place within these religious communities, which is profound for health and potentially for much else as well.
Tyler,
Can I have a
thank
word?
you.
Can I?
One last
coming from-
question, and then we're going to have to cut off here. Go ahead, Leonard.
Harold, can I ask a question from Africa?
Sure, go ahead and ask.
We
This will be
live
the
in a-
last question.
We live in a very multicultural society with many strong religious groupings. So I've written an article to help physicians understand what you call the spiritual history. And I've titled it rather looking at belief systems. In our world, and this is not the Western world, we have multiple belief systems ranging from animism, monotheism, polytheism, atheism, and many other belief systems. So I'd like you to comment on the whole issue of ensuring that people's belief systems are healthy and how that contributes to their mental health. That is something that I would love to hear more about. Thank you.
You know, again, I think this relates somewhat to the last question. I do think it is important to look at you know, tradition-specific measures of spiritual well-being and practices that might differ across different religious and spiritual traditions and belief systems. I think that work is empirically is still, especially with regard to longitudinal studies, at a very early stage. Most of these studies are in the West, large proportion in the United States, and with all-cause mortality. There are a handful of other rigorous longitudinal studies in Israel and Taiwan and in China, but we're almost completely missing rigorous longitudinal data on say Muslim and Hindu populations. So a lot of work to be done there, and a lot more work to be done on rigorous longitudinal studies for you know, aspects of religion and spirituality beyond service attendance as well. So to try to facilitate this work, we're actually in the process of launching what we're calling a global flourishing study in collaboration with Gallup. It's funded by the Templeton Philanthropies, and this will be a large longitudinal cohort study of 300,000 individuals in 22 countries, representing about 2/3 of the world's population, religiously, culturally diverse countries, and we'll be following them up once a year for at least 5, possibly 10 years. Collaboration between Harvard, Byron Johnson at Baylor, and Gallup. We will have a somewhat richer set of religious and spiritual measures. And so we hope over time, it'll probably be a good 5 years before this is possible, but to be able to look at these different aspects of religion and spirituality across countries, across different religious and spiritual traditions, to see you know, where the evidence is similar and where it's different. And my speculation at this point is that with regard to physical health and all-cause mortality, we'll pretty consistently see community participation leading to lower mortality risks. I think the effects on mental health and other aspects of psychological well-being, my speculation will be that those differ considerably more. But this is speculation at this point, but we are in the process of trying to create this data. It will be an open access data resource. So once it's available, you're all welcome to make use of it, analyze to your heart's content. But we really do hope that this study, Byron Johnson, I very much hope that this study can empower research on religion, spirituality, and health, as well as the determinants of well-being more generally. So I'll hopefully be back in some years' time to present some of the preliminary analyses of that work.
I sure hope so, Tyler. I sure hope so. Thank you once again for a great presentation, and this will be available for any of you to review again on our website, so I encourage you to go there. Otherwise, thank you to all of you for participating, for your wonderful questions. God bless and stay safe.
Thank you all. It really was a pleasure being with you today.